This video provides general information about osteogenesis imperfecta, or OI, to schools, licensed childcare facilities, and agencies providing respite. It is based on the standard material produced by the Unified Referral and Intake System. Osteogenesis imperfecta is also known as brittle bone disease. The primary issue is fragile bones that break easily. People with OI have less collagen than normal or a poor quality of collagen. Other health issues they may have include weak tissues, fragile skin, muscle weakness, and loose joints, bleeding, brittle teeth, hearing loss, vision problems, breathing problems, and curvature of the spine. OI is highly variable, ranging from a mild form to a form that is fatal prior to or shortly after birth. It is classified by type. When providing care for a child with OI, it is important to focus on their specific abilities, strengths, and weaknesses, instead of on their OI type. The characteristic features of OI vary greatly from person to person, even among those with the same type. Type 1 is the mildest and most common form of OI. Type 2 is the most severe. Infants with type 2 usually die within weeks of delivery. Type 3 is the most severe type among children who survive the neonatal period. The degree of bone fragility and the fracture rate varies widely. Type 4 can range in severity from relatively few fractures to a more severe form. Type 5 is moderate in its severity. Type 6 is extremely rare and is moderate in severity. Treatment focuses on minimizing fractures and maximizing independent function. Treatments may include physical and occupational therapy, casts, splints, or wraps for fractures, braces to support legs, ankles, knees, and wrists as needed, surgery, often including implanting rods to support the long bones in arms or legs, medication, mobility aids such as canes, walkers, or wheelchairs. For children with limited mobility, the physical environment may prevent their full participation in activities. Common barriers may include steps at entrances or between floors, restrooms with narrow or heavy doors, high sinks, and narrow stalls, play structures, and hands-on work areas such as science labs and woodworking class that are inaccessible to a child who uses a wheelchair or is of short stature. These barriers should be addressed if they interfere with the child's ability to participate. Possible strategies to address these issues include portable ramps and wheelchair lifts, lowering equipment such as lockers, shelves, and soap dispensers, providing a lower desk or work surface, providing the child with adult assistance in the restroom if necessary, allowing the child to leave class early to avoid crowds and allow more time to get to their next class. Allow the child to select a seat that is more accessible, such as near the classroom door. Provide an extra set of books that the child can keep at home so they do not need to carry a heavy load. Participation in physical activity is important for children with OI, as it helps to strengthen their bones and muscles. This may require creativity and planning, but it is a vital part of their education. Physical education teachers should involve the child in the same activities as their peers whenever possible. They may be able to wheel or walk around the track while others run, go to bat while another child runs on their behalf, or kick a ball while sitting in a wheelchair. Consult with the child's parent if you are uncertain if they should participate in a specific activity. They may be restricted from playing contact sports in which injuries are difficult to avoid. A helmet or knee or elbow pads may be recommended for some activities. Properly fitted shoes also help to support the ankles and prevent falls. It is also important for children with OI to participate in recess activities as much as possible. They may be able to use traditional playground equipment with or without adult assistance. Other children may need to be reminded to play safely. Rough play or carelessly thrown balls can place the child with OI at risk. A child with OI may move more slowly than others and be at risk of a fall if moving quickly or exiting the building with a crowd of people. They also may require the use of a wheelchair or other mobility devices to evacuate safely. It is important to establish and practice a child-specific evacuation plan to prevent injury. A child with OI may need assistance when getting on and off the bus. They also may need to sit in a section of the bus that offers the smoothest ride. For some children with OI, other transportation options may need to be explored, such as a wheelchair-accessible bus or van. The following signs may indicate a fracture. The child complains of pain that gets worse with movement. Swelling or bruising over a bone. A deformed limb. The child not using a limb. The child winces or looks uncomfortable during routine play or exercise. If any of these signs are present, call the child's parent. If you are unable to contact the parent, call 911. Inform medical personnel that the child has OI. Do not move the injured area unless it is absolutely necessary for the child's safety. If you are moving the child, try to keep the affected area as still as possible. Make the child comfortable. If they become chilled, provide a blanket. If they are nauseated, provide them with a basin. Do not provide food or drink in case the child needs surgery. Apply a splint if the parent or medical personnel has instructed you to do so. Makeshift splints can be formed using a pillow, towel, or magazine wrapped around the affected limb. It can be secured with strips of cloth. Do not tie the splint too tightly, as this may cause pain and decrease circulation. The nurse will provide additional information, if necessary, on specific needs of children in your care. Instruction on how to respond to potential fracture is also included in their healthcare plan. If you do not know which children in your care have OI or how to access their healthcare plan, talk to your administrator.